telling me that. So it's my honor to present on CTNNB1 in the eye. I'm Drew Scoles. I work in Philadelphia as a retina specialist for kids and adults. So we know, thanks to a study by our host for this meeting, that eye abnormalities are very common in children with CTNNB1, 93% of which show some sort of eye abnormality. And the severity is very variable. It can go from very mild or asymptomatic to blindness at birth. The risk of progressing to more severe disease is not fully understood at this point in these kids. And we don't, at least I don't believe that we have a complete understanding of the genotype-phenotype relationship of the severity of the ocular disease. So what are the ocular findings? This is from the same study. Strabismus is by and large the most common finding in kids with CTNNB1. And strabismus, as you can see in the two photos at the top right, is most commonly esotropia, where one eye drifts in, or exotropia, where one eye drifts out. The eyes can also go up or down, and they can go diagonally. Any combination thereof is termed strabismus. It's a misalignment of the eyes. And you can see I put in a figure here from another paper that in this group of kids with CTNNB1, although they're not trying to show strabismus, it's very common, and almost all the kids in this sort of photo series here have some ocular misalignment. Now, just talking a little bit more about strabismus, I don't think that this is strictly a genetic related problem. I think it falls more into the category of a motor delay, like many of the other problems that have been discussed in CTNNB1. And what I mean by that is the connection between the eye and the brain is not as mature as it probably could be. And so the alignment of the eyes is a little bit less rigorously controlled. And that can improve with time and particular therapies that I'll go over later. But it's just a characteristic motor delay, not necessarily a genetic problem. The next group of eye abnormalities that I want to highlight is refractive error, meaning the need for glasses. And that's relatively common in kids with CTNNB1. It's also common in kids in general, but it may be a little bit more so in these children. And it's important because without the right glasses prescription, the vision doesn't develop appropriately, or kids who didn't have strabismus could develop strabismus just because they need glasses. What I really want to highlight today, though, is FEVR, FEVR, familial exudative vitreoretinopathy, which was relatively common in this large cohort of patients with CTNNB1. So what is FEVR? In the top right of the screen, I have normal picture of the retina and the retinal vessels, and also a normal angiogram. The black and white picture in the top right is an angiogram, meaning we inject dye into the body and watch the blood flow in the retinal vessels. So FEVR is a vitreoretinopathy, meaning it's abnormal vitreous and abnormal retina that's characterized primarily by vascular changes. And so the earliest stage, and this is the description from my mentor, Michael Tracy, is just a lack of complete retinal vascularization. So you can see in this picture in the top left, stage 1, where the vessels end. They end prematurely because the development is incomplete. In and of itself, that doesn't necessarily threaten vision. But stage 2 disease often comes from stage 1, and stage 2 is characterized by the development of new vessels called neovascularization. These vessels are problematic because they can bleed, they can leak under the retina, and they can detach the retina. And so you can often prevent stage 2 disease by treating at an earlier stage, like stage 1, or you can prevent stage 2 from getting worse by prompt treatment. And we'll talk more about that later. What's often been described in kids with CTNNB1 is more severe disease. So that's stage 3, where there's a partial retinal detachment that's sparing the center of the vision, or stage 4 disease with a more advanced retinal detachment where most of the retina is detached, or stage 5 where the retina is totally detached. And that's typically what's been described in CTNNB1. And I'll go over that also in a little bit more detail. But first, why does FEVR happen? So I have figures here of the norrin-catenin signaling pathway. I don't have time to go over the whole basis of this and how it's involved, but suffice to say it's critical for the development of the retinal vasculature. And there are many genes that are known to cause fever involved directly in this pathway, and I'll highlight a few of them here. So norrin, frizzled 4, T-span 12, LRP5. These are kind of the most common causes of fever. But you see what's downstream is beta-catenin, and that's the purpose of our discussion today, is to go over the effects related to that. So it's not a surprise that since beta-catenin is sort of the downstream signaling pathway of the other molecules that are known to cause fever, that we see fever in these children. There are some other genes that are less common, but it's important to know that in kids who we clinically suspect to have fever, up to 50% of the time we don't actually find a gene. So there's still a lot that we don't know about fever in general. Right now it looks like CTNNB1 is a minority of fever cases just because it's generally quite rare, but we may learn more with time. So how does the genetic change cause the disease? Well, retinal angiogenesis has kind of two critical time points. One is the retinal vessels that are present during embryogenesis have to go away. So what's present in the womb should not be present in the born child. And defects in the norencatenin pathway can cause incomplete regression of the embryonic vasculature, and that can lead to congenital retinal detachment or all sorts of congenital anomalies that fall into the spectrum of fever. That's one possibility. The other possibility is if the embryonic vasculature does go away, but the sort of adult retinal vasculature develops abnormality because of a signaling change, that can also lead to the sort of phenotype of fever, or you can have a combination of both. And so this is why the sort of norencatenin pathway is so critical in this disease. The sort of phenotypic findings characteristic of fever, meaning too many retinal vessels with abnormal branching, neovascularization, retinal folds, retinal traction and detachment, these are all related to abnormal retinal vascular development, something that starts in the womb and then continues throughout development prior to birth. You can have progression of fever after birth as well, and that's just related to the eye being set up for problems because of abnormal retinal vasculature. So one thing that's really important, and you notice immediately when you read about CTNNB1, is that oftentimes the severity of eye disease is quite significant, meaning if you look at a bunch of the series that I kind of highlight here on the left of the slide, most, if not all of the eyes have stage 4 or stage 5 disease. And that's typically because these children are identified at birth, and often their retina problem is identified before they're known to have CTNNB1. That's just because it's easier to see kids, have an obvious visual problem at a very, very young age. If the kids see pretty well, then oftentimes you may not know that there's a subtle fever. And what I mean by that is, in my cohort, I had children of 8 eyes, and I had 2 stage 0s, no problem, 4 stage 1, 1 stage 2, and 1 stage 3. That kind of goes against the typical characterization of fever. And that's because it takes a little bit more investigation to find early stage fever in children. So I have an example, and this is maybe my most important slide. I think that we're underdiagnosing fever because it's hard to see at earlier stages. So I saw a young girl who was followed by an excellent eye doctor, and she had been seen for 7 years and never noted to have eye changes consistent with fever. But I didn't examine under sedation because I was concerned that we were maybe missing something with a fluorescein angiogram. And she actually had stage 3 fever, which required immediate treatment to preserve her vision. We're missing fever in kids because it's hard to examine them in clinic because of the sort of neurocognitive delays, maybe behavioral issues, and you just simply can't do it. Plus, at least in my opinion, a fluorescein angiogram is mandatory for the diagnosis and screening for fever in these kids. So does this matter? Yes, I think it does, because I believe that if we can intervene earlier, then we can improve outcomes. And my final point on this slide, which may be the most important, is kids like those with CTNNB1 will often end up with retinal detachments later in life, and we blame them for hitting themselves in the eye. That may not always be the case. It may be that they had a preventable retinal detachment related to early stage fever. And so it really kind of highlights the importance of identifying these kids comprehensively. So I'll just conclude by going over what I think we should be doing for kids with CTNNB1. It kind of has 2 different parts. One is visual development. And what I mean by that is things like strabismus that we talked about, the need for glasses, amblyopia or lazy eye, anything along those pathways should be followed by a pediatric ophthalmologist. With regards to fever, the screening really should be with a fluorescein angiogram, and oftentimes that needs to be coupled with an exam under anesthesia to get an adequate view of the eye. And that can be done by a pediatric ophthalmologist or a pediatric retina specialist. And how often you have to do that is kind of determined by what you see. Treatment earlier is better as well. And so along those lines of visual development, prescribing glasses, doing realignment surgery for the eyes if needed, patching a lazy eye, for example, these are all things that should be managed by a pediatric ophthalmologist. With regards to treating the fever, if you have a pediatric retina specialist available in your area, it would be good to get them involved in the treatment, which sometimes is simply observation, sometimes can be laser, and sometimes in more advanced cases of detachment, they need a sclerobuckle or vitrectomy. But we don't know what the kid needs unless we properly identify them early. So I just wanted to conclude by saying what's already been said, which is that this is a complex disorder and requires multiple specialists, but can involve the eyes often and threaten vision. The sort of visual prognosis varies dramatically depending on the kid, but oftentimes can be determined by when the disease presents. So very early presentation at birth of vision loss or retinal detachment has a very guarded visual prognosis. If the kids have relatively normal vision at birth or early on, then it's a pretty good prognosis, but we still need to follow them. And we have to remember that vision is more than just the eyes. It also involves the brain and the connection between the eye and brain, which can be delayed in kids with CTNNB1. So the next steps in learning more about the eyes in CTNNB1 is to just continue to follow our patients and make sure that they have good ophthalmologic care.